Well, welcome everyone to what I think is a really important topic, but probably sadly something that's somewhat played down in Huntington's disease. So this is on self-neglect and what we can all do about it. Okay, so about today. This really comes from the perspective of me as a UK healthcare professional. And so, therefore, the policy I refer to is UK based, but the content is just as relevant to Huntington's disease the world over. So, what do we mean by self neglect? Well, perhaps let me set the scene. In 2014, self neglect became a category of harm and abuse under the UK Care Act. The Care Act is the legislation used by local authorities and councils to determine the support needs of vulnerable people who need their care and support. There's a tendency to think that harm and abuse comes from others, but actually, what is recognized in the Care Act is that harm can come from yourself, and that has been recognized, and that's a really powerful position. So, local authorities and councils have a duty to explore it. But I want to bust some myths. Self-neglect is not just hoarding. So let's look at that a little bit further. So this series of dominoes, if you like, is the South Tyneside self-neglect guidance document. And what it refers to is that neglect or self-neglect is this tendency to neglect self-care to the extent that it threatens personal health and safety. But it has some knock-ons. That means that it's not just about your personal hygiene, it's also about your health and your surroundings, which is what we're going to talk about in some of the case studies. As a result, often what will happen, and certainly in my clinical experience, is that you'll have also an inability to avoid harm as a result of the self-neglect. You will draw attention and unwanted attention to yourself. It's a failure to seek access to services which could help, and it's an inability and sometimes an unwillingness to manage one's personal affairs. So more importantly, why is this such a serious concern in Huntington's disease? Well, first and foremost, I'm going to put it out there, and that's why it's in bold. It's not a choice. There are specific brain changes which lead to this problem. And I'm also going to say that there are life events which influence the risk. For many of you on this call, you may have heard professionals say, well, it's just a physical disorder. And we want to bust that myth. And the Huntington's Disease Association has done countless exposés on this. But the other thing that goes along hand in hand with this is the default response from people with Huntington's disease when questioned, which is, I'm fine. And we're going to talk about why that is in a moment. 38% of people with Huntington's disease live alone in England and Wales. That's a really, really high figure. And you might say to me, well, Alex, that's a choice. But I will actually come back to you and say my experience is that, yes, for some people it's a choice, but for others it's a not. It's actually a result of a breakdown in social and support networks that lead people to live by themselves. And then therefore they're not taking part and not able to necessarily access or proactively advocate for themselves. So this group of people is highly at risk of self-neglect. There's a socio-economic impact of this disease, which drifts through the generations. Losses of jobs and losses of opportunity can lead to some really devastating financial impacts, which in turn have the ability to impact on self-neglect. And we're going to talk a bit this at the end, but there are consequences here for child welfare, and there's potential for homelessness as well. Okay, this is when I lean into my teeny tiny screen a little bit. I've tried my varifocal glasses, but it's not working. So brain changes. Okay, what are the consequences of these brain changes? Okay, I've put these in order of how they sort of tend to appear in the chronology of a disease from what we know so far. First and foremost, communication. Understanding and expressing abstract language is impaired. Things such as using the telephone become really, really difficult. So perhaps you get a referral for somebody and you're on the telephone to them and you're speaking quite fast and you're using abstract language. You might want to play that down because invariably the default response is I'm fine, because that person is really struggling to express themselves. Executive dysfunction. This is the kind of glue that holds all of your skills together. The chief executive of your company. Executive dysfunction means that the person is having difficulties problem solving, organizing themselves, forward thinking, judging risk, and that leads to difficulties in responding to mail, filling in forms. And that can often be seen as a lack of engagement and a choice, but actually it's not. It's a consequence of brain changes. And again, you'll also get that response, I'm fine. People are often discharged at this point, and I would discourage that. Social cognition. For those of you who have not heard this, this is an ability to, or an inability, I should say, to understand one's own and others' thoughts and feelings, as well as feelings and signals in an environment. So let's think about the emotion disgust. Okay, disgust is can be moral disgust, but it also can be a signal for that something is bad for us. And it comes with lots of modalities such as smells or hearing or feeling. But actually, people start to lose those. People with Huntington's disease start to lose that ability to understand these negative emotions. And we think that that plays into self-neglect. Neurological apathy. This is apathy isn't just an inability to undertake a goal. It's multidimensional. For example, let's think about social and emotional apathy. You know, that shrug, that looking like that person doesn't care anymore. But this also comes from neurological change. So this isn't just he is apathetic, he is lazy. This person is really, really struggling to turn those thought processes into any actions. Agnosonosia. This is, known as a lack of insight, a lack of awareness. It is not psychological denial. Sure, that happens early in the disease process, in fact, pre-disease process. But actually, in my experience and in the evidence, it's present in some form in nearly all patients. So therefore, why would you engage with something if you just genuinely don't think that you've got it or that there's no consequences? And again, you'll get that response, I'm fine. Sometimes there are things such as obsessionality. So, for example, you'll see in the red flags with collecting animals. There's a tendency to use things such as the word obsession and perseveration together. But obsession often has a personal connection. If I don't do this, this will happen. It tends to be in Huntington's disease more around perseveration. So that person gets stuck on a thing or an idea. and it's like the record is stuck. Okay. But then there are also things such as confabulation, which is filling in the gaps. So you think, okay, I know this has happened, and I put this together with this, and I actually give quite a good account of myself. But often or not, it's completely the opposite to what you see in that person's space. Sensory changes. We know that there is a problem with information processing and the speed at which people process it. But if we take information to be sensation as well, heat, light, touch, pain, that changes too. And again, in my experience, people become defensive to water on the skin. It's been described as needles on the skin. There's also sensitivity to noise, and then a sensitivity to all of these things bombarding you and becoming quite overwhelmed and withdrawing. So we need to be aware of those things. One of the most underestimated things for me is fatigue, um, because the brain is really, really struggling to keep up with the amount of information that we have to process. That actually a person's batteries run really, really low. They have this minimal residual capacity. And we all know what it's like when we're fatigued. We just don't bother, do we? So if we have apathy and fatigue and a problem with our executive dysfunction, we can see why these things become so difficult for people and neglect sets in. And then last but not least, are physical changes and overall functional decline. We tend to think about balance and coordination, but how about undoing the top on the fabric conditioner, for example, or actually how about working out how to wash when these things are happening to you? So all of these things are playing into what we're seeing. There's a caveat, though, to that. I'm not saying that everything is due to brain change. I'm not saying that. We must also look at things such as acute issues and manage them. And of course, if a person is self-neglecting, they are going to be more prone to UTIs and constipation and so on and so forth. Weight loss. Okay, we know that it is innate to the condition, but we also know that it's related to functional issues. And the reason I'm putting it in here is because we have problems with a very low battery, that fatigue, that residual capacity, but we've got weight loss on top of it. And that might make us more prone to not necessarily undertaking things that are important to our self-care and our environment. Depression. Depression can be treated and should be treated, although in people that are cognitively impaired, they will struggle with taking medication on time, and so therefore that needs to be overseen. Psychosis. I have seen people who have really, really self-neglected themselves and their environment due to a psychosis that was not picked up, which can sometimes look like it's perseveration or obsession. And that's when you need to see your Huntington's disease professional to try and pick apart what's actually happening for that person. Intergenerational trauma. This is a disease that comes through generations, and trauma itself has an impact on the way the brain develops and how we respond to situations. So that needs to be explored. There needs to be this trauma-based approach, but we also need to consider that perhaps people have had role models that have Huntington's disease themselves and have taught them or maybe not taught them how to self-care. So we need to consider that in our formulation. But I want to be very specific that we shouldn't sit on the psychological side of the fence or the physical side of the fence or the brain change side of the fence. What we need to do is we need to put all of these things together to acknowledge these are running alongside of degenerative change. So this disease is dynamic. Okay, these are the risk factors and red flags that I would look for. And handily enough, the South Tyneside self-neglect Guidance has put them together for us here. And these are indicators of self-neglect. So I've already spoken about collecting animals, but it's things such as a person having a very poor personal hygiene, odor can be a problem, an unkempt appearance, not having enough food in the house, not actually maintaining a property, living in squalid conditions. These are probably things that sometimes you, as a loved one or a companion of a person with HD or a professional, you can be really embarrassed. You feel really that it's a really intrusive thing. But if we continue to ignore them, well, you'll see in a moment what actually happens as a result. So be curious, do observe, do smell, do touch, do ask if you can, and if it's safe for you to do so. So what can we do? Advanced planning, it's never too early. Keep trying, document small changes, even if somebody tells you just to pierce with a pin and push off. Notice changes. It might be smears on, I don't know, paintwork. It might be a little bit of feces. It might be urinary incontinence. Check in gently to see if that person is noticing them too. They might not be, and that's an important clue. And don't let them necessarily build up. Offer practical support. Check the fridge. Jimmy Pollard, who was on yesterday, talks about cognitively remodeling the environment to optimize function. So thanks to Jimmy. Set routines. I mean, this person is now has executive dysfunction. That means that they can't necessarily figure out what's supposed to happen when to have a shower, why it's important. Be what I would call meaningfully directive. So you have to be clear in your communication, not abstract, and make sure that it's meaningful to that individual. Set up the environment so that it's meaningful, so that people want to do those things. Be creative. What's your language? What's that one thing that might work? What's the domino effect? Make sure that there is a physical health check done and involve your HD nurse or consultant support. Follow your local self-neglect safeguarding process. There will be one for your local authority. And if you're a professional, make referrals to social work, fire brigade, housing. What resources are there locally? Get together a coordinated plan, and it must be multi-agency. You can't do this by yourself. And the reason I say that is because Bernard's case took upwards of 200 hours in 1 year from the group of people that were working with him. And that's about time, and that's also about relationship building. Capacity assessments, they will be specific, but they'll also be related to one another. Tenancy, care, and finance are all interconnected. And be prepared for change. This is a degenerative and dynamic disease. So this is a note on capacity assessments in Huntington's disease, and I'm calling it the 3D capacity assessment, rather like a Toblerone bar, okay? You look at it from one angle, it's 2D. When you look at it from another angle, it's 3D. People with Huntington's disease often have very intact semantic memories, and that means that they can retain and recall everyday information. They look like they understand what they're doing, even in very precarious circumstances. And our questioning, you might not have thought about this, often provides the framework, the executive framework, which then helps them work out answers. This is a common problem in post-brain injury, and it's often called the frontal lobe paradox. And I've given you loads of links at the end of this presentation to explore those ideas. So healthcare professionals are observing that sort of rinsing and repeating the same risky patterns over and over again. And absolutely, whilst everyone's entitled to make unwise decisions, we know again about Huntington's disease cognition in that it impairs insight and executive function. But Huntington's disease is more than that. We've also got behavior that is impacted by apathy and impulsivity. So therefore, a capacity assessment must be 3D. What do I mean by that? 3D capacity assessment is a not just a one-off interview style capacity assessment. Material time, so is the time that relates to that decision and any information that relates to that decision, whether that be in the past or whether that be in the future. Okay. And that's why I say about care and tenancy and financial impairment all interact, and we should be taking those into consideration. Because the deficits in a person's cognition fall into executive dysfunction, we should be asking this person to weigh up and communicate the scenario being put to them, which means that a 3D capacity assessment allows you to say, you said this or you did this, but you did this. Why is that? And chances are, if that person can't tell you that or they can't work it out, then the chances are that they lack capacity. It allows you to explore what is called flashpoints, this fluctuating capacity, a refusal or an inability to take part, and explore methods which incorporate observation alongside previous assessments, which allow for when an individual is struggling with this complex language. And Neil Allen, who's a barrister at Essex Chambers, said that 3D capacity assessments are necessary requirement for robust capacity assessments for people with suspected executive dysfunction, which is what you've got going on in Huntington's disease. So these are related concerns. We've already spoken about the fact that financial impairment and debt is really common. So it's a huge red flag for executive dysfunction, and it's often occurring alongside self-neglect. So use that as a red flag. Sarah Mason gave a brilliant presentation, which I think is on the webinars on YouTube, on financial impairment and why that happens in Huntington's disease. A sensitive subject, but Huntington's disease is occurring at a time when people are their parents, and there may be a neglect of children that we need to take into account. Children are very protective, and again, they'll also say, I'm fine. But we do have evidence that due to a lack of insight, affected parents may prevent them from accessing support. So we need to be professionally curious. Homelessness. Oh my goodness, I've spoken to a number of people in the last few weeks that this inability to manage a property and a tenancy, people become so cognitively overwhelmed that actually they are asked to leave the property, and they often end up on the streets. Then what happens is that sometimes when people pick them up and they're returning from prison, for example, or from the street, that there are resettlement difficulties due to the original problems in the first place, this overwhelm and this lack of skills. So people have to be aware of that. As professionals, we have to be aware of that. As you've seen, moving house can be super difficult. It's what the most stressful thing for us, I believe, and when we're cognitively intact. But executive dysfunction, cognitive overwhelm, and rigidity require extensive support. And then I think it's worth bringing these to your attention that there have been serious case reviews about self-neglect. And one of them is that we've already said that self-neglect makes you more vulnerable to other forms of abuse. So people have had people moving into the property and cuckooing, which, if you're not aware of it, is like having a cuckoo in the nest that takes over. So, for example, people who might be doing drugs move into the property and take over. Sadly, death. People are seen as unwilling to engage rather than unable.